Wow. That was a little bit like being at your own funeral. So, can you guys hear me? Because I have to walk, because I literally have just come in from Fort Morgan, where I just finished the first leg of Pedal the Plains, and so you'll see me walk like, what? She just got off a bike. I just was riding a bike for the governor's big Pedal the Plains tour. If those of you in the room that ride for, or ride the Rockies, this is not Ride the Rockies. This is the race for the rest of us. It's flat, and it's fun, and it's long. Janet, thank you. What a gracious introduction. It's not me, it's a team of people, and it's Colorado, because we are a really extraordinarily collaborative community. And I want to talk about a lot of things going on, and as you guys, as I just confessed, getting off that bike, I'm still a little like adrenaline, because I don't have a lot of time to work out these days, but it was a great race, and it is great to be here. But I also get that between you and that wine is me. So I'm going to be very brief and let you ask all sorts of questions. So anyways, thank you so much. What a privilege to be here and to talk about everything that is going on. And, you know, I want to just preface by saying whether you like Obamacare, which I will refer to as ACA, PPACA, healthcare reform, whether you like it or not, it is here to stay. So I kind of, as I tell my kids all the time, life's not fair, buck up, deal with it. So that's where we're at. We have to deal with it. And I am really proud that here in Colorado, we are really embracing this and really trying to take our own destiny into our hands. So I want to talk first about why healthcare reform can be such a huge opportunity for us. And the thing I'd like you to know is that we need to become the healthiest state in America. Now, we recently just beat out Montana, and we are the thinnest state in America. But in order for us to be the healthiest state and have a healthy economy, we've got to get everybody really being productive and really functioning at their max capacity. So a little myth busting today. Did you know that almost 87% of my Medicaid clients, my over 1 million Medicaid clients, work? 87% of them. And so I want to tell you that this whole notion of creating a healthier state and healthy economy, we've got to make sure that everybody's performing kind of to their peak, whatever that is. If you're in a wheelchair, let's get you at your peak health. And I know I'm preaching to the choir. But we really are committing here in Colorado to champion kind of new ways of thinking about healthcare. And I'm going to break up the different parts. But I tell you this because really healthier citizens, you know, it's one of these like news bits, you know, healthy people cost us less. And so we like this notion that we, in our department especially, being the largest state agency now, we create crowd out for other really important programs that we need going on in our state. And so we know that we've got to do everything in our power to create value. But really the first thing that I want to remind you is that we've had a really incredible track record here in the United States. We've got a heck of a sick healthcare system. I mean, I think we would all agree, especially if you have coverage, you get some pretty incredible care here in the United States. And we all know, and I won't get into it because you guys are such experts yourselves, but it's really, there's no uniformity to anything, not to our systems, not to our care, and we waste so much money. One of your big benefactors, Martin Hart, and I used to talk. He built that beautiful tower outside. And I'd say to Martin, it's really a travesty. We waste money in America because we can, and we can't do that anymore, you guys, because it's ruining kind of our other critical elements. So I tell you this because the basis for all this opportunity, this cycle of change, is really around not going backwards on our fabulous acute and sick care systems, but bringing up health and wellness. So it's exciting. It's a really exciting time. And if you think I'm not excited about this or positive about it, I just think there's just lots of room for us to grow. So let's start about some of the critical elements. You guys all know about the triple aim. I'm not going to tool you or reschool you on that, but I'll talk about one of the things that's most important is getting covered. And there's got to be this huge transition to make sure that people understand that coverage is really critically important, and access is equally as important. But first and foremost, we've got to get everybody covered here in Colorado, and this is an extraordinary effort. I'm really proud to be standing up here now. Last October, I was absolutely like practically getting an ulcer, wondering if our systems, when we flicked them on, would stay on. But we in Colorado, when we set out, this administration took over, when was it? January of 2011, that's hard to believe. But we had almost 1 million Coloradans that were uninsured. It was right, a little shy of that. It was 800 and some thousand is what the book said. And we went, wow, that's a huge, tall order. In this first enrollment period, we have signed up 411,530 people. And it's because everybody has leaned in. We did some really incredible work about working with Department of Regulatory agencies and doing some webinars to nurses and physicians saying, hey, you see these folks, it becomes kind of this conversation you need to have of no longer is it what, do you have health insurance? Now it's what kind of coverage do you have? And so I tell you this because Medicaid's been extraordinarily expansive and the state-based marketplace has been extraordinarily successful. And this movement of getting all these folks in has really been a team effort. We were, you know, there's a silver lining in everything. CBMS, that horrific benefit management system that was around for a decade, really created some problems for us, but it also created massive opportunities because we had a stakeholder group that was really championing getting people in. So they had all sorts of people in the queue and lined up. And so when we did flip the switch on all the technology, eligibility and enrollment went really well. So Colorado right now, our statewide uninsured rate was 18%. We're down to 11%. If we... So think about this. We're going into the next enrollment period starting November 15th. That'll be when you know, all the big marketing and all the drums will get beating again for really people get covered. And but we could really get 90% of Coloradans, 95% of Coloradans covered in this next enrollment period. Took Massachusetts 5 years, guys, and we could be accelerating, leapfrogging. And it just means each one of you are ambassadors. Each one of you, when your neighbor says, oh, my kid doesn't have coverage, or should I get the school insurance? And you have to know enough to say, wait a minute, have you already been checked out for Medicaid or CHIP, or what about your employer-sponsored insurance? And I'll talk about that here in just a second. So it's very exciting that, there's been some amazing shifts that have gone on. The Cover Colorado, our state program, enrolled more people in getting us covered, which is a federal program, and all of those things kind of have matured and continue to evolve. But let's see here. By 2013, only 43,000 Coloradans reported that they could not get coverage because of pre-existing conditions. And in addition, because some of the policy choices that we've made since then, now no Coloradan can be denied coverage because of the pre-existing conditions. So again, this whole notion of, that the healthcare.gov site didn't work and eligibility is not working, that's not true in Colorado. It worked, our state-based solution worked, and we just have to keep promoting it. So that is the one bit of homework, I'm giving everybody homework, you've got to take away, is you play a role in promoting this coverage. And it does really reflect, too, in the bottom line of our financial institutions, our partners that are reporting to us that, boy, we are getting some relief off of having a pay source for all these clients that are coming in. So let's talk a little bit about, the next slide, the Medicaid benefits. So that's the other thing that I think is really interesting. I think everybody, or maybe just me because I'm a policy geek, but there's a new thing called EHB, the Essential Health Benefits. And so we've leveled the field now. I think everybody gets it that the Medicaid benefit really is no different than the Kaiser Silver benefit. That was I see lots of heads like, I'll accelerate. Some audiences go, what is she talking about? But I think there's a lot of myth about that, oh, that's the Medicaid benefit, or that's the old way. And we've got to really change that. So I tell you that because this is the list of all the things that are covered. And this is going to modernize yet one more time here real soon when the feds call for the next EHB modernization, and that won't be too long. And it means we all have to really provide input about what's really important. So I just tell you that because I'm always also, second bit of homework, always looking for committee members, people to help us shape this system here in Colorado, because we, again, control our own destiny, and we can tell the feds what we want in our EHB. So I just think it's really exciting to, again, that we can kind of customize what works for Colorado and certainly works for our Medicaid program. So another huge success that we accomplished, I don't know if any of you know this because you don't have a school of dentistry yet, but we did put up an adult dental benefit for the first time ever in Medicaid history. So that's been really, really exciting. And I do think that the dental provider incentive program and some of the incentive programs, these are investments that we're making in transforming the system. So we've been working really closely with the Dental Association to get more dentists here in Colorado. We've been launching, as I said, these incentive programs to encourage more dentists and hygienists to take Medicaid. We've got a program called Take 5. We're like, take 5 minutes, take 5 calls from us, take 5 patients, take 5% of your practice. This has not been easy. I would really encourage all of you to beg your dentist to start taking Medicaid because our rates have really come up, but we still have a real challenge. It's interesting, dentists want to get into cosmetic now. Nobody wants to do kind of the old regular preventative stuff. And so this is another area that I really need your help on, but we're still really working to get final approval with our federal partners to create more shared savings, to create more performance incentive bonuses. And I think we'll see this industry really come alongside. The Dental Association has been a really great partner with us in trying to really move their dentists into kind of more modern times. We were really, really pleased, and it was Senator Jeannie Nicholson that really led the charge on dentistry, but the General Assembly, you know, another thing you can do is thank your legislators. You know, this is all pretty overwhelming from them. What? You want to cover 1 in 5 Coloradans on Medicaid and you want to open up the benefit and you're trying to tell us this is going to save money? And I'll take you into the bowels of that here in just a minute, but it's just really important that we keep kind of assuring folks too, and you guys know it because you are our providers that are making these changes, but we need to help them kind of understand how this works. But one of the things I think that is the biggest thing you can help me with is to kind of get rid of your own old Medicaid stigmas. And what I mean by this is we've got to create this massive culture shift about coverage. And people need to start understanding that right now you have a continuum of coverage. You can be in public programs or you can be in private programs. The public programs, ours, Medicare, TRICARE, Indian Health Service, all these are considered CHIP, all of these are considered public health programs. Now, because we've got Connect for Health, our marketplace and exchange, people up to 400% of poverty can get a subsidy. So right now in Colorado, over half of the folks that came in on the exchange are getting about $260 a month relief or subsidy off their insurance benefits. Now, let me just put this into perspective because you might be going, what's she talking about? Families of 4 that are, a family of 4 that are making less than $94,000, it might be off a few thousand, it's in that 90 range, can get a subsidy. And so it makes, I mean, healthcare insurance is really expensive, and so it makes it really easy. So do you consider that subsidy a public insurance, or do you consider it private insurance? And who really cares, you guys? We're healthcare providers. What we care about is people get covered and get a primary care medical home. And I tell you the third part of this is private health insurance because these players here are enormous partners now. They are starting to act more public, and public is starting to act more private. And this continuum is going to continue to blend, and it's really, really critical that you guys start helping us reshape the public side of this, and we are. We've put out enormous bonuses and shared savings are coming on the street. And that's going to move our payment reform that I'm going to talk about here in just a minute. So again, that homework helped me go find those last 400,000 folks. So it's no small feat. We're 5th best in the country. We got, you know, we have this huge surge of clients, and I know I get stopped all the time saying, great, Sue, you've opened up the floodgates, and now we are overwhelmed. And so I say, calm down. The thing we're working on right now that is exhausting is we're working on service delivery reform. And so this transformation, what's really important for people to get is that the old systems, the old thought of, well, I'm a nurse, I am a nurse. I'm a nurse and I work in a hospital. Or I'm a school nurse and I work here. Or I'm in aging or public health, and or I'm only interested in, what's another one that I always hear about? I'll pick on a different profession. The doctors, sometimes I get a bit of, well, we're primary care, and then the subspecialists and the specialists. And the locations, well, I just am gonna be in a nursing home. It can't work that way anymore. And you guys, I know, are just, again, leaders about team-based care, but our systems have to transform to umbrella, manageable units of functionality. And I know I have some old public health friends here, but public health has got to wake up and get in this game, and we are trying to drag them in because I think they continue to struggle with, well, we don't just deal with payers, or we don't really want to deal with payers, and it's really not about payers anymore. It's about coverage and how that plays in, because part of what we're trying to do is trying to figure out what's the right risk arrangement for different providers. Some providers are going to go under full risk payments, and you might be going, what is she talking about? That's that old capitation word, or the old managed care words. And we have these abilities now with risk stacks and shared savings and performance bonuses. So what I think you'll see for the future is you're going to see service delivery systems, and these are already happening under our 1281 launch. But these are really going to be amazing when we can say, here is your base capitation, and here are your performance incentive bonuses, and here are the shared savings off the system. So I'm really excited in Colorado that we led our state a little bit more thoughtfully, a little slower with the launch of these RICOs. Just a side note, Oregon jumped in. I love that Governor Dr. Kitzhaber. He's really a great guy. He's a very cool emergency doc. But he jumped in and said to the feds, I want a $2 billion challenge. And he said, give me the money, we'll show you returns, we guarantee you a 2% reduction in your cost trend. And boy, Oregon's having a hard time keeping it together right now because they didn't layer in kind of, okay, we gotta be methodical, we gotta get primary care up and going. Then we gotta get specialty care going. And we gotta get public health in the game. So we've been a little bit different here in Colorado. We didn't do the money grab. We said we're gonna build the primary care base. Right now we're bringing in specialty, we are bringing in public health, and you'll see this continuing evolution of how we're going to be shifting care with the dollars. Because I got to tell you, a little news flash, you guys, fee-for-service, in my opinion, in 5 years, it will be dead. Dead. But not completely dead. Because there's a risk stack that goes on. There's lots of capitation or lots of full risk folks. You remember those guys I showed you on that private side? Arkansas has already gone under full risk. They put their entire Medicaid program into full risk. And guess what? Those private guys love that risk because they pack it into profits for their stakeholders. My belief in Colorado is that these local units of functional delivery system need to reinvest this money back into a healthy and well system for their communities. And it's going to go far beyond healthcare. It's going to be, what do we need to do to prop up more with supportive housing? What do we need to do to infuse more money into higher ed and pre-K through 12, because these things create those little burdens on the social determinants of health. Oh, by the way, housing. We have such inadequate housing inventory in Colorado for supportive housing, but we also can't think of, what is she talking about, housing? We can't think, well, traditional nursing homes. We've got to look at how you infuse kind of affordable housing into projects, and I just love your Cultivate Health project. It couldn't be more online. And I actually talked to your housing people and your land use planning people, because we've got to infuse, we know that segregation of populations is a real problem. And so it's going to be great to have some affordable housing units, some disability housing units, some aging housing units, and all of those things have to be happening in these more functional systems of care, these more functional integrated systems. So it's very exciting that delivery system transformation is going on. We have these 7 regional care organizations here in Colorado. They are geographically based, but they're statewide. You know, it's hard for people to believe, but we had really, really uneven primary care. And certainly even in public health, we would see, you know, we had whole regions that didn't even have basic access in certain areas. So these accountable care collaboratives are going to do those very basic things. Every client's going to have a focal point of care. Every client will be insured to get client-centered, comprehensive primary care. Their care will be coordinated. There will be unprecedented levels of data. And we've got almost now, this is what I think I might be most proud of, but it's never me, it's a whole team of people. But my folks have loaded 700,000 of our clients into these regional care systems here in Colorado. And we are saving lots of money. So I want to show you this because we are going into year 3. And we have, oops, Ellie, go back. Oh, maybe I don't have that one. I'm sorry, see, I just had a little hypoxic moment from the bike. Let me get a sip of water. Well, before I go take you into the cost savings, the other big transformation that's got to happen is culture of workforce transformation. So we've got to really continue to look at our provider network. And when I mentioned a few minutes ago, we've got these proposals before the feds, and some of them are improved, but we've got new incentives for accepting Medicaid clients. I'm really thrilled right now. My staff have been like, what are we doing? We're getting 100 to 150 new applications a week for providers wanting to be Medicaid participants. So I think people are kind of getting it that, wow, you can't, Medicaid is now such a big part of the care, the whole care proposition that you can't avoid it. So that's been really exciting. But we are pretty pleased that we have almost, actually that slide's a bit old, but we have just over 40,000 providers in, that are Medicaid providers. And that's been a really significant increase there, as I've shown you. But that's not good enough for us because we've got to, as I said, figure out more of these performance incentive bonuses and get people in. And the next big thing that's happening, and the governor has tasked us, we're working with the National Governors Association because we're doing this entire workforce transformation. We are really looking at what needs to happen with all the scopes to get people practicing at the top of their scope. So it's a very exciting time, lots more work happening with workforce. I'm sure Janet's gonna school us all the time on what to do next about workforce transformation, but we definitely have some committees. You know, we're one of 6 states that really made a commitment to the primary care rate bump and extending it. So we are using state general fund dollars. Do y'all know what I'm talking about? Does everybody know about the 1202 bump where I see some heads? So we pay additional dollars to really strengthen and build the primary care system. Those were federal pass-through dollars, but now we went before the Joint Budget Committee last year and said, you know, our primary care base we were just planting it, it was just incubating. You cannot, you know, let these dollars stop. And we said, look, we've got savings from all sorts of other systems transformations going on, so let us reinvest those back into our primary care. Let us continue that rate bump. So that is going to be going forward. And there right now are 4,200 Medicaid physicians, nurse practitioners, and PAs who receive an average increase of approximately $25 per office visit for primary care services. So we know this is an area that's got to be transformed and shifted, but right now we just needed to make sure, as that surge came in, that we had enough primary care capacity. I think it's no secret. You've read the newspaper. Denver Health has some issues. You know, they're in a bit of a challenge because they are such a big provider. So they have certainly worked with us to look at what they're going to do to get their wait times down. Kaiser's got some issues right now because of the surge, because they were one of the big winners on the marketplace. And these things are public and we're dealing with it, but we're also kind of all in this together, so we keep looking at where we can kind of reattribute folks to. But I will tell you, the biggest worry I have about provider network and all those carriers and that coverage continuum is if providers don't take all pay sources, guess who's going to suffer? Not the providers, because they get to cherry pick and see who they want. But who's going to suffer are the clients that need continuous, regular, steady care. And so if they have to flip out of Cigna's network down to Medicaid's network, and then, oops, they pick something on the exchange that's not in either network, we could really see some horrific bouncing. And that lack of continuity of care, I mean, you guys know, if you are having PT and have to shift out of your, beloved physical therapy services and go somewhere else, that's a huge problem. So we know that is something that's really got to happen here really quickly. It's more stabilization of the provider network. So I am also here to tell you that, these first few things aren't big enough. Let's see, we've said coverage, we've said service delivery, we've said workforce. We aren't overachieving, all of us together. We took on payment reform. And I've talked about this a little bit, but House Bill 1281 gave us permission to bring up a payment reform methodology to fund things differently. And I am really pleased to tell you that we're one of the first big pilots in the country. So this will help us have different various payment demonstrations going on. And we received 10 proposals statewide. We picked one. We had all sorts of independent evaluators. And so where's my HSA dean guy? Where's he, the director of the health services? This is the kind of stuff where I love students at my shop. Oh, thank you. So just know that we are always trying to bring in students and interns and precept. But we had the Center for Improving Value in Healthcare. We had an independent actuarial firm. It's always great for students to kind of watch like which levers they're pulling, you know, what are they doing? But this was really great. In July, we selected Rocky Mountain Health Plans. You guys, I think, know, I'm sure Janet has told you about all the tremendous success that's happening out on the West Slope over in Mesa County. And these guys will be our first big movement, and they started moving in September. And so they are getting a monthly capitated payment, but it's got some side rails, it's got those performance incentives, and it will have some more shared savings. And so we're really excited about this work. There's several other that are baking, kind of in concept, that we'll be announcing probably in the next few months. But over the next 2 years, we're going to be looking to implement all these additional payment models, because once we feel like we can kind of flesh out which of these models are best for our clients and our our clients and our providers and our networks, we will probably look at trying to standardize more of that. I will tell you, for those of you going, she is crazy, I'm not naive. We are never going to have everybody in full risk, or, you know, we're just not. So, you know what I described as that risk stack? You're going to have a lot of people in full risk. You're going to have some people in partial risk or kind of protected arrangements. And then you will, at least I will, forever keep some things in fee-for-service. So, you know, for example, I get this list all the time now about like, hey, so here's your liver transplants for the month, or here's your heart transplants, or here's you know, some of your big cost outliers. And it's better for us to be able to negotiate those one by one. Just an interesting side note in case you're getting bored, but stay awake. Stay awake, we're getting to the wine. But an interesting side note, I was traveling yesterday with my chief medical officer, Dr. Judy Zerzan. She's another phenomenal person, and we love these students shadowing us, so please send us your best and brightest. But Dr. Zerzan looked over at me as we were driving down I-25 and said, oh, you know that, you guys know about Sovaldi, and I know, where's my pharmacy section? Okay, so Sovaldi, hepatitis C, $1,000 a pill here in Colorado. How many weeks? No, I'm not a real nurse. Is it 26 weeks? Oh, okay. And there's a lot of arguments. I get calls all the time. I get practically hate mail from some infectious disease doctors who say you should give it to them for 52 weeks, and you should give it to everybody. Do you know what it does to the Medicaid budget here in Colorado? The hepatitis, I see some blank stares. So hepatitis C has a new drug, and it's called Sovaldi. It's $1,000 a pill. It cures hepatitis C. Right, guys? Where's my pharmacist? Correct me. Somebody fact check me if I'm wrong, but I think I'm kind of right. Anyways, in the Medicaid population right now, we have 100. We go through a prior authorization process. We have 100 on. They cost us $10 million. If we blew open and gave Hep C for everybody that some of these docs want on this new drug, guess what it'd do with my budget? $2 billion for one pill, for one drug, Sovaldi. Anyways, back to the story. We're driving down the highway. My doc says to me, oh, guess what? Next week, the next hepatitis drug is coming out, and they're pricing it at $100,000 per treatment. So Jan and I have a little side project that we're going to do on bioethics, but that's a different time, a different conversation. But I tell you this because this risk stack, this way we're going to pay, there are some things that are going to be outliers. There's going to be some areas where we just absolutely have to try to keep our arms around some of these shifts that are truly happening kind of on a quarterly or unexpected basis. But all right, let's keep moving because I'm almost done. Got to keep you awake. So I want you guys to know that it's really important that we keep working together here in Colorado. And I can't thank you guys enough. Many of you serve or call me, or Janet certainly does. We talk every now and then. But I do want to clarify, because some people go, Is she the lady that runs the health department? And yes, I run HCPUF, as Janet told you, but this is a really great way to help you, and I know you guys are all advanced superstars, but HCPUF is the first column. Department of Public Health and Environment has an enormous role. We pay them about $6 million to regulate this whole crazy environment, and we're trying to transform rules and regs. We're moving into a smart reg framework. They also do a lot with health, wellness, and prevention. The Department of Human Services is a massive partner of ours. All of these are what I refer to as my sister agencies. But Department of Human Services plays a really enormous role. Because just remember, you guys, you know, we're all high achieving and perfectionists. Even if we deliver perfect health care, we're going to only impact 10% of that person's health and well-being. I mean, that's pretty sobering. If we do not work on their housing and education and all the other components, clean air, clean water and air, we got some pretty major problems. I tell you that I was so lucky this week to go down to the tribal nations. Colorado has 2 tribes. We have one of the wealthiest tribes in the world, Southern Ute. They own pretty much every amazing city in the world, or parts of it, though they truly are. They were so lucky to be placed on a reservation that has just about the most extensive natural gas resources. So you have the very wealthy tribe, and then literally less than an hour away, you have one of the most kind of challenging environments with the Ute Mountain Utes. One of the most sickest tribes. The average life expectancy for tribal, there are 2,000 tribal members for a male, 49 years. 53 for a woman. I spend a lot of time in Africa, you guys. We have to keep working. The air and water down there, I mean, there were just some issues in housing. There was just basic sanitary things that was just really frightening. And it really triggers my sister agencies because we have to have this concerted effort on dealing with health disparities. DORA, Department of Regulatory Agencies, I love it that they are coming alive with us. They allowed us to do the big webinar out to our nurses and doctors on education. It's another thing I'd love to talk with Janet about how we push out more to you guys, where you get a little reminder, to, hey, you can do this webinar sometime. And I think we have to look at how we continue to educate people about all this transformation, because this change is really, really hard. Division of Insurance plays a massive role, and when our governor gets reelected in November, we are going to really encourage him to think about a little different kind of health regulatory environment out of DORA. And I tell you this because, you know, how are we going to start monitoring integrated systems? You know, there's amazing things that happen in integrated systems, but how are we going to really modernize and really have kind of an oversight role? We're seeing some very interesting challenges right now as integrated systems come up. Some good things, some not so good things. And then Connect for Health, that marketplace that I talked about. So these are the sister agencies that I deal with all the time. And I just think it's really important because it does necessitate a move on state government structures. And so I venture to guess that it won't be long till we'll be kind of thinking about, do we need a health authority? Do we need a different kind of utility? Who, for example, we are the state designated entity with COREO and QHN. You know, those are those big EHR. I know you guys, I love it. You talk my language, so I don't have to explain to you. Some people look at me like, what the hell is a health information exchange? But really, electronic health records and whatnot, you know, we have to really start looking at these become necessary utilities of kind of our emerging work. And we don't have really tight controls, and we have to keep looking at how are we going to continue to modernize this. But all of this means we've really got to work closely with these agencies. And we have been, so I would venture to guess that we can always improve, but I do think it's been a sea change of forcing kind of our senior teams and our employees to spend more time together, and that's been really fun. I have to say, coming out of the public health world and out of rural frontier Colorado, that's the only way we got work done. I can't tell you how many times the fire chief or the police chief would call me and say, hey, the river's up and the flooding's happening and so-and-so's, you know, her little bungalow's right on the river and you guys, you know, you do the home care on her, I need you out there. And we would work cross-jurisdictionally. That doesn't happen at the state level. And oh my God, newsflash, you guys, at the federal level, we just had Peggy O'Kane here from NCQA. And Peggy was like, look, we can't even get the 5 big HHS divisions to agree on quality metrics. So I just tell you that because movement of some of these really entrenched systems is no small feat. And I spend a lot of time right now with our federal partners going, we're not going that way because we're going in a different way and we can go faster. So anyways, I do think it's, again, a very interesting time, lots of opportunity. But now I want to take you into kind of just 5 more minutes on kind of the future. And I want to tell you, if you didn't see the New York Times last weekend, the article called Beyond Marriage, the one that talked about, I see some heads nodding. You know, in America right now, babies are like being born into families that only want one single head of household. This is creating huge shifts, and that article by Isabel Sawhill is really fabulous. The other article is about ending poverty, and it talks about all of these kind of social determinant issues and how we have to really laser in focus on some of the, not only the health programs. I mean, yes, we're worried about you know, when your entrance into prenatal care was, or what your baby's birth weight was, or what the immunization status is. But my God, we have got to really couple these with well-being. So I think you'll see a much bigger push here in Colorado on our very disparate, vulnerable populations, which, by the way, of our million Coloradans, over 1 million Coloradans right now, 600,000 of them are low-income kids. And I saw just recently that we've just started to slow our huge increase in children living in poverty in Colorado. We were like in the top 10 worst in the country, and we've slowed that down, but we got so far to go. It means our public health partners and our DHS partners become more and more of our best friends. Anyways, the Colorado Opportunity Project is one of the things I think you'll see. I know this is going to sound crazy, but we really believe, and I think there are some incredible evidence-based programs, both on the health and the well-being side, that if we got a lot more targeted and focused and we rearranged our team-based care, that you can permanently move people up and off of poverty. Why do I know that? We're spending a lot more time with the labor economists who will talk to you about where that income instability is and how you can really boost people if you just get them up, right up over 250. And so we've got to get better about probably a little bit more of a commitment to Coloradans about how we do this work. The other big thing that I will just brag about, because I use your Cultivate Health program all the time, I hope that we will see 7 RICO regions have this kind of neighborhood model, this infusion of land use planning, housing, health, education. I told these guys not to make you all worry, but it was really an honor to be sent by Robert Wood Johnson Foundation down to Cuba, probably a decade ago. I tell my kids all the time, one of my claims to fame is that I beat Michael Moore there. But say what you will about Cuba, because they got a lot of problems, but boy, do they have some interesting primary care and health care delivery value going on. But this very much reminds me of what we saw there, where you embed primary care, where you embed services right into the neighborhoods. And that is, you know, all health is local. All health decisions are yours and in consultation with your loved ones, your providers. But that's what we got to get back to. So I just tell you that because there's some really cool examples. The other example, and I know I'm rushed for time here, but health, wellness, and prevention. How are we going to do this? You might be going, what are we going to do? Because, you know, we got all sorts of great walks and runs and bike rides, and we got all sorts of obesity stuff, but boy, we aren't really embracing some of our health, wellness, and prevention in a new way. I'm really pleased that we are going to be pushing our federal partners on trying to let them allow us to put more of our clients on all these new cool devices that I know are not secured right now. This is my Fitbit, in case people are going, what is she waving? But this thing has gotten me off the couch more in my 10,000 steps. But I will tell you, it's far beyond that. We're working with University of New Mexico right now to bring Project ECHO here. Project ECHO is amazing. And you need to write this down. You guys, this is virtual grand rounds. And this is strengthening of primary care. This is demonopolizing knowledge. And these guys, 40 sites all over the world, Department of Defense has them, VA has them, and Colorado's going to have them by the end of the year. Project ECHO is coming to Colorado, and you'll be seeing how we can do more team-based, it's de-identified kind of grand rounds with experts. And so what they've done with Department of Defense, so back to hepatitis C, they've got some of the best infectious disease doctors that used to have wait lists out 9, 12 months, and now they are in consultation with the primary care providers, teaching them how to be better providers, but still getting to see the specialists when they need to, but not unnecessarily. So I just tell you that there are some really, really exciting. We are definitely recognized as a huge leader, and there's some numbers up there. I'm really pleased that Commonwealth Fund and AARP and recently ASTO and others are giving us some good grades, but it takes incredible work. I'm not going to talk about the statewide HIE because that will really put you to sleep. I think the thing I want to leave you with is, I cannot not tell you about the state innovation model. So where are we going next? To me, one of the biggest movements is going to be with public health and behavioral health. So what you're going to see is we have to keep really, really building the base on primary care. And no longer can we just take care of physical health needs. We have really got to push people on mental health needs. And not just mental health, but guess what? We got so much substance use disorder, and SUD plus mental health equals behavioral health. And so we are really going to push, and we have a $100 million grant in the queue right now. And you all, many of your industries, I think, Janet, you all sent in a letter as well. We have filed for a $100 million transformation grant to really do that, so create bidirectionality. So your physical health providers, your nurse practitioners and your docs, everybody that's a physical health provider, your PTs, are going to have a little more training and education about what to start watching for in mental health things. And the mental health folks are going to move towards more physical health. And we call this bidirectionality, and it's like common sense. But it's not happening. And we're going to look at how we're going to pay differently and how we're going to really mobilize. So I tell you that, and I will stop in closing. There's lots on the horizon. There's lots in this crystal ball that's starting to gel. Our federal partners sometimes say to me, so you all are moving too fast, and I say not fast enough. We are wasting money, and lives are at stake, and we can do better. But I do have to stop and say thank you for all of you, because we, in the last 4 years, I think have done more to reset kind of this Medicaid realm in Colorado than anywhere else in the country. So it's truly an honor to be working collaboratively with everybody. We're here to listen. We're here to take your great ideas. And yeah, you need to co-create with us, because this thing is one big, hairy, audacious project. So thank you. Let's go drink.